Today I will show you a video of performing a percutaneous dilational tracheostomy at the bedside in the intensive care unit. Today's PDT is performed by Professor Sanghon Park from the Department of Thoracic and Cardiovascular Surgery, with Professor Yeonjoo Lee from the Department of Pulmonology assisting by performing bronchoscopy. During the preparation phase of the PDT procedure, it is important to ensure adequate neck extension when positioning the patient. Before performing PDT, it is advisable to review a CT scan that includes the neck region, or use ultrasound to check for any veins running anterior to the trachea. From the top, identify the thyroid cartilage, cricothyroid membrane, and cricoid cartilage in sequence. The usual puncture site for PDT is between the second and third tracheal rings, just below the cricoid cartilage. Palpate the area carefully, confirm the midline, and mark the site. The patient is already sedated with agents such as midazolam, and additional local anesthesia is administered using lidocaine. Although a vertical incision is commonly used, a horizontal incision can also be made to avoid interference with a sternotomy incision. An electrocautery device is prepared for hemostasis, but in most cases dissection with only a mosquito forceps is sufficient to expose the trachea. Once the trachea is exposed, the endotracheal tube is withdrawn slightly from the patient's head side so that it does not obstruct the site where PDT will be performed. Then bronchoscopy is inserted, and when the light from the bronchoscope becomes visible through the trachea, external pressure is applied to confirm the correct location. Next, a fine needle is used to puncture the trachea, and the position is reconfirmed. A 15-gauge introducer needle with a sheath is then inserted. At this step, the bevel of the needle should face downward to facilitate the downward advancement of the guide wire. When inserting the guide wire, ensure that it advances toward the carina rather than upward, and confirm its direction under bronchoscopic guidance. After the guide wire is inserted, the first dilator, a 14 French introducer dilator, is used. Next, the tracheostomy dilator, which is curved and gradually tapered, is introduced. This tracheostomy dilator is inserted while assembled with a guiding catheter. When removing it, the dilator is withdrawn while leaving the guiding catheter in place. Subsequently, the loading dilator and T-cannula, pre-assembled together, are advanced along the guiding catheter into the trachea to insert the T-cannula. Before this step, both the loading dilator and T-cannula should be well lubricated with jelly. At this point, the endotracheal tube is completely removed. Next, inflate the T-cannula balloon and connect the ventilator. Verify that the ventilator displays appropriate pressure, flow, and volume curves, confirming that the T-cannula is correctly positioned within the trachea. If necessary, bronchoscopy can be continued, and a transtracheal aspirate culture may also be performed.